Ready?
Yeah.
Okay, here we go. 5, 4. Are you introing? I guess I didn't clarify
Yes,
that.
I'll do it. I don't know.
3, 2.
Hello, and welcome to Middleish, the podcast about moderation in all things. I am Erin Green.
And I am Michael Gray.
And This is our second episode doing our second long full-length episode doing our new format. So
Yeah, we're kind of just getting our toes in the water. Yeah.
We have a treat for you. For those of you who have been listening since our first year, we had Dr. Spencer Nadolsky on I think it launched, I looked it up, episode 22 on November 2nd of 2020. So
2020, that's when it all happened.
Just pause
right in the middle of our collective trauma.
Totally. Just pause and think about everything that has transpired since then. And it's kind of mind blowing. When I went back and saw that date, I was like, oh my gosh, in some ways it feels like it's been a time warp, like no time has passed. And in some ways it feels like a lifetime has passed.
Yeah, for sure.
So thank you. That sums it up.
Yeah, it's good to have you back,
Spencer.
These are the bright spots. These are the bright spots, though.
So thank you for joining us. I'm just going to kind of, for those of you who did not hear our first interview with Dr. Nadolsky, Dr. Spencer Nadolsky is a licensed, practicing, and board certified family physician who specializes in bariatric care and lipidology, which is really important to our conversation today. His philosophy is one that pushes lifestyle over pharmaceuticals, which of course we love. And we can talk a little bit about that because pharmaceuticals still have a place, but we love the idea of encouraging people to, take control over their health and change their lifestyles. Dr. Nadolsky completed his undergrad at University of North Carolina, where he also wrestled in the heavyweight division for UNC Tar Heels. His experience in athletics shaped his approach to medicine, using lifestyle as the primary intervention for patients. He is known on social media as the Doc Who Lifts and specializes in memeology on Instagram, which I can testify is one of my favorite facets of your medical practice. So
it might be my best specialty, though.
I think you're great at it. And I haven't found any other memeologists that I would like to follow. So good job.
No, that's true. Yeah.
Now,
can you write a meme as a prescription? Because that would be great, right?
I've done that before.
So is there anything you'd like to add to that, telling our audience about what you do and some of your interests?
Yeah, just basically, so my whole thing is, trying to push lifestyle as much as possible. And then, if we have to use pharmaceuticals, whatever, no shame in it. So we have to do it. I just, obviously there's lots of doctors out there where it's a system issue, or they don't have a lot of time. And they go straight to the prescription pad before just even asking a patient if they'd be willing to think about some sort of lifestyle plan. That's it. So I may have to reword some of the way it is, because there are some doctors out there that are like, no, prescriptions are bad. You got to do lifestyle only. It's like, well, no, got to do them if you got to do them, but see if we can do the lifestyle thing. So that's kind of my motto. I am a little bit different of a doctor, not just because of my weird videos and stuff I make on Instagram, but more so I'm all in the cloud now. I got out of the clinic in 2017, right at the beginning of 2017. So 5 years now I've been not in a clinic at all in the cloud doing telemedicine. And I have coaches that do nutrition coaching, and then an online lifting workout plan, that kind of a group exercise plan. And then I do all my telemedicine one-on-one through various programs. So kind of a different model of the more efficient, less archaic way compared to the current model of medicine. So that's basically what I'm doing.
Awesome.
Go ahead.
Sorry, go ahead. No, go ahead.
I was just going to say, I think it's cool that you're doing a lot of telemedicine, because I think you could probably reach a broader audience and make it more accessible that way, and kind of create what the patient needs versus sticking with that very, clinical sort of rigid structure that we have in traditional medicine?
That was the whole concept. You have to have I have 28 different licenses, so I have to be licensed in all these different states to do it legally. So I'm able to reach a lot more people. People can then reach me. They don't have to fly to see me. So it's kind of cool.
Yeah, that's awesome. And then you've kind of shifted your work a little bit recently, kind of focusing more on just sort of people who are introductory to exercise and eating better and taking better care of themselves. Do you want to tell us a little bit about that shift and kind of when and why that happened?
I've always been about trying to help, kind of regular people. I was being an athlete in college at Division I. It's like, all right, everybody's like, you're going to be a sports med ortho doctor, really focusing on super Olympic athletes. And I was like, no, that sounds horrible to me. It's not fulfilling. It's like, cool, you benched a little bit more, you ran a little bit faster, you swam fast, whatever your sport is. That doesn't really seem fulfilling. I really wanted to get people who were on their pathway to an early death or early disease state and veer them off the other way or help them, reverse or put into remission their chronic disease. So that was always kind of my focus. And, I was working with another company where their focus was more on those more fitness kind of fanatic type of individuals, where now I've found a way to reach these people. So that's why I call it Lift RX is my group exercise program. Lift RX, because I'm a doctor. I don't know what else to call it, lifting prescription. But it was a cool name. I was like, all right, this is cool. So
I like it.
The idea was to get I think everybody should lift weights, and exercise of some form. A lot of people are scared of lifting weights. You go to the gym, you see some meatheads and, they're grunting and growling and you don't even know what kind of exercise you're doing. You see people posting about people doing incorrect form on exercise and you're just like, why would I even do this? People are going to make fun of me. I feel intimidated. So the whole point of this was to make a very safe space, group format. We have a Facebook support group, and then we have an app that delivers our videos where it's me and a physical therapy, doctoral physical therapy student who's also a certified strength coach and a master's in kinesiology. And I kind of play this doctor role. He plays the super technical strength coach. And I know what patients ask because I've prescribed lifting before, but I may not get as technical as a strength coach. So we kind of play this thing where I do the exercise or he does the exercise. And then we start talking about common mistakes. And we've able to come up with a way to really make people go, okay, I understand the technique now. And I don't feel afraid of doing it. So you can do it at home. You can do body weight to start off with. Then we have a minimal equipment one like dumbbells and bands if you're doing it at home. Mm-hmm. Then we have a full-blown gym one if you have a good gym at home or if you go to the commercial gym. So we have 500 people in the group, and it's just a fantastic support group. And I'm looking to hopefully get it up to 5,000 over the course of a year or so, and above that. But that's kind of my grand goal. Mm-hmm. And then obviously, if you need nutrition coaching, then I'm going to be launching that full scale soon. But same idea, working on just starting and being consistent as opposed to being intimidated by these big crazy workouts.
That's great.
Taking the first step, and that's essentially it.
That's awesome. One thing I've always appreciated about you is you're really good at taking kind of complex things and making them real simple. Like you're talking about with exercise, making it really approachable, because it can be intimidating, and I think things medically can absolutely be intimidating for most of us, but you're really good at breaking those down into really easy to understand concepts. I think that's what makes your memology so good is you can take a concept and just have, just a couple lines. It's like, oh yeah, I get that. I get why that's important. Or I get how to apply that kind of thing. So that's one thing I've always really appreciated about you.
Thank you.
And with that in mind, let's pivot into, and we're going to put you on the spot now with this. Oh, nice. So let's veer a little bit into just start talking about heart health. So when we're looking at, a healthy cardiovascular system, there's a variety of things that impact that and what that looks like. Can you just kind of give us a brief intro into what what are the things you're looking for when someone's, wanting to improve their cardiovascular, their heart health? And what are the common things that you see as kind of stumbling blocks for them just when they're beginning to do that?
Yeah, most people think of like heart health as in like cardiovascular disease or not having cardiovascular disease. There's other things going on, but like, so when you have a heart attack, it's actually the arteries that supply the actual heart, the tissue, the heart muscle tissue. So when you have a heart attack, it's one of those things gets blocked off at some point. So then it's like, okay, then how do we keep those vessels to the heart tissue nice and open and working well throughout life, so we don't have to have a heart attack and end up in the hospital and end up on all these medicines and have chest pain that really affect our quality of life, or dying. Obviously, we don't want to die either. So there are certain risk factors. They've been doing this. They've been looking at this for years, trying to go like, okay, these people tend to have more heart attacks, tend to have more strokes, kind of similar. We have arteries up in our brain too. And all over the place. Your legs, peripheral artery disease is what they call it when you start getting blockages in your legs. But same thing with the heart. So what are these risk factors? So things like smoking, obviously, when you get older. Cholesterol, we'll talk about. I'm a lipidologist. I'm not a cardiologist. I focus more on the lipids and preventing cardiovascular disease as opposed to necessarily treating it once they have it, although I still do that from time to time too with a cardiologist. But so what are those risk factors? Trying to keep people super healthy and lean and exercising and all these different things. So what kind of questions do you guys have for that? Do you have any off the top of your head?
Yeah, well, I love that you pointed out that cardiovascular disease is also taking care of the supply highway, I guess, to the heart and the brain, right? And so some people just think it's like, oh, keeping my heart healthy, but you need to keep the whole body healthy, really. And that's what we're talking about. And I do get quite a few questions, especially the population that I have been working with lately tends to just be middle-aged to like kind of post-retirement age individuals, and they tend to be very active and they want to really take control over their health in the best way possible. So they're already active, yet they're looking to me for these dietary recommendations. And I, of course, am very familiar and comfortable talking about that. But because you're a lipidologist, I want people to hear from another source. What are some of the specific nutrition kinds of things that you talk about with people to prevent heart disease?
Yeah. So there's a few things to understand. That so when we look at a cholesterol panel, you look at there's like total cholesterol, and then there's this LDL cholesterol, HDL cholesterol, and then there's triglycerides. And it's like, okay, the LDL is kind of this bad cholesterol, they call it. What does that actually mean? Well, there's these proteins that carry cholesterol through our blood. The low density lipoprotein cholesterol is carried on these low density lipoprotein particles. These are the type of particles. I don't know if I want to get technical. This is Middleish. Am I supposed to get advanced or really simple? I don't know.
Wherever you want.
You can get advanced and then bring it back. Yeah.
You can bring the smart, I'll bring the dumb. Okay. And we'll wind up in the middle.
Pretty much any type of particles. And there's a bunch of particles in between. There's very low density lipoprotein. It doesn't really matter. The only ones that we don't have to worry about are the HDL particles. Those ones do not start plaque buildup or atherosclerosis. So these other ones, we call them ApoB containing particles. This is apolipoprotein B. It's this little protein that cholesterol is carried on. We know mostly we call them the low density lipoprotein. That's the most abundant one in our system, the low density. That's why we call it the bad cholesterol. But the cholesterol is not necessarily bad. It's the protein carrying the cholesterol. The reason we have to have these is because when you put oil into water, it's hydrophobic. It doesn't mix. So in order to put cholesterol or lipids and circulate them, we have to carry them in these little proteins. Well, there's a specific one, this ApoB. These particles, and again, the most abundant one is the low density, the LDL particles. These are the ones that can get into our arteries and become stuck. And then our immune system and everything starts attacking them, and we start this formation of little fatty streaks, and then atherosclerosis, and starts building up, and then they can break off and then cause a clot in our heart, one of the arteries that goes to our heart, and then can kill us, whatever. So that's why we say when we want our LDL cholesterol low, it's a kind of a surrogate or an estimate marker of how many of these particles we have. We want to keep that low. So what are the things that actually keep that low? And that's only one component of our cardiometabolic health, as we'll talk about in a second. And that's where a lot of these debates between low carb keto people and the low fat vegan people, they all start getting in fights over what really matters. It all kind of matters, but this is just one component of it that matters. So in order to keep your LDL particles low, or your ApoB containing particles low, that you see the general advice, like keep saturated fat low, don't eat so much cholesterol containing foods, eat more soluble fiber. All these things do play a role. So the thing that controls our bodies, the blood amount of these LDL particles, it's really our liver does a really good job at circulating and recycling it. So the better our liver is at recycling the blood, the particles that come in and keeping it out of our blood, the better. The thing is with saturated fat, and it gets really confusing because there's multiple different types of saturated fatty acids in the foods that they come contained in. So when people say saturated fat, it's like, well, what does that even mean? Are you talking about butter? Or are you talking about, yogurt? Are you talking about meat? Are you talking about chocolate? All these different types of foods have different types of saturated fatty acids. And the reason we call them saturated fatty acids is because it's based on the biochemical structure. It's biochemistry. And again, I don't want to get too advanced here. So just understand it's just kind of the way that the chemical structure is. So the reason they call them saturated versus polyunsaturated versus monounsaturated. These saturated fatty acids, there's different types of them. They come packaged in different foods, and all these things can play a role in how well it affects our own cholesterol or LDL particles that are floating around. So having said that, in general, saturated fatty acids tend to downregulate our liver's ability to recycle our LDL cholesterol. What this means is that the cholesterol and particles in our blood starts to increase because we're not recycling it as well. Polyunsaturated fats, so things from like nuts and seeds and even fish oil, but in general, like nuts and seeds are where we probably get the good sources from it. Those tend to upregulate the liver's ability to recycle. So our LDL particles go down. And it may be separate from the fact that we're not getting as much saturated fat as well. There's different effects going on. So if you lower your saturated fat just without replacing it with anything, we're gonna lower our cholesterol. If you then replace it with polyunsaturated fat, you may have even further decrease. And then there's monounsaturated fat. Most people know this as like olive oil, other types of nuts like almonds, and even seeds. Peanut butter has monounsaturated fat. Avocados, that has a good effect on our LDL particles too. So the practical takeaway is to swap out as much of these saturated fatty foods as much as possible with mono and polyunsaturated fatty acid foods. So for example, if you're putting butter on everything, you switch it to olive oil. If you're eating coconut oil. If you're using coconut oil, use avocado oil instead. If now chocolate, again, it gets kind of complicated, but chocolate has this certain type of fatty acid called stearic acid, and it seems to actually have a neutral effect. So that's kind of one of the rule breakers.
Interesting.
So I like chocolate, so I use that as an excuse to eat more chocolate. So,
sure, naturally.
But I would
Heart
say,
healthy.
but butter, coconut oil, probably the biggest ones. And then, I'm not telling everybody to drink corn oil or something like that, but I would probably go to more of those whole sources of more polyunsaturated, monounsaturated sources. There's actually a diet out there called the portfolio diet. If you look at that, it shows you all the different ways to basically lower your cholesterol, your blood cholesterol, through diet. So then we get to, what about dietary cholesterol? Like, I heard eggs don't really affect us, and then sometimes they do. It has an effect. It's just not nearly as much of an effect as saturated fat. The reason is, there's multiple reasons, but so when you think about eating cholesterol, we just think it just kind of gets into our blood and then it kind of clogs our arteries. I don't know, but our body's much smarter and complex in the way it regulates it. Our intestines, actually, the most cholesterol in our intestines is actually from bile. The cholesterol that we have mostly in our intestines from bile, 70 to 80%, whereas only like 20 or so percent is from diet. And then our intestines have certain proteins that help us absorb that cholesterol over into our system. And then again, it's still tightly regulated with our liver. So it's true that eating zero cholesterol, like if you go vegan and eat mostly plant-based, that extra little bit of cutting out dietary cholesterol will have an effect. It just won't be as much as the saturated fat and polyunsaturated, monounsaturated fat. And then I think the second, so I think dietary cholesterol is the third most important, saturated fat, polyunsaturated mono is the first. The second most important is probably soluble fiber. And this is what plays a role. The reason I mentioned dietary first, cholesterol first, is because the soluble fiber actually may bind up not only the dietary cholesterol in our intestines, but also that biliary cholesterol in our intestines. And what that does is, when their bodies isn't detecting as much cholesterol or actual bile being reabsorbed, our liver goes, oh gosh, we better upregulate our ability to take some of this cholesterol out of the blood, because we need to make more bile. It's kind of an interesting thing. So the soluble fiber probably plays a bigger role. And if you replace your saturated fat calories with soluble fiber or poly and monounsaturated fat, either one, my general recommendation is, if you're just trying to keep things simple, if you're eating refined carbohydrates, replace them with more soluble fiber containing carbohydrates. So like if you're eating, most people don't go from eating rice to lentils. Most people eat potatoes, right, whatever. But okay, so if we're trying to be more apples to apples, I would say if you're eating rice or something like that, try to eat more beans and lentils in the same, because you're going to get that much more soluble fiber out of the carbohydrate, right, and that will help bind some of the bile in our intestines and start lowering our LDL cholesterols a little bit more in our blood. So that's there's a lot of complicated pathways and things going on, but the gist is swapping out some of those saturated fat stuff for poly and monounsaturated, right, eating more soluble fiber. And then on top of that, the cherry on top would be eating fewer cholesterol containing foods. Again, that's not as much of an impact though.
That's great. No, that was a great explanation.
I love it.
I didn't get lost once.
Good. Yeah. Good job. That's impressive.
I get a sticker?
You should, yeah.
So
I just want to do a quick summary of that, because I think for some people that have not heard any of this before, that it might,
it's a lot,
sound really complicated.
This is
Middleish. So here's my attempt at like a Middleish explanation. And if I misspeak, you just, hop right in. So basically speaking, you have different kinds of molecules in your bloodstream that carry the fat around. Okay. LDL contains some particles that get sticky in your arteries and veins in your blood vessels. So if you have too much of
mostly arteries.
Mostly arteries.
That is one of the people like, why don't we get atherosclerosis in our veins? It has to do with the blood pressure, because the blood pressure in our arteries is strong, whereas in veins it's passively coming back. That's one of the reasons. So anyway.
Oh, that's interesting. No, that's good. That's good. Okay. So can get sticky in your arteries. The blockage is what ends up causing a heart attack or stroke or, death. So we want to prevent that. Your body is really good at regulating this if you give it the right kinds of tools. So we want to give our bodies the right kinds of fats in the right proportions, and to basically help it prevent some of that stickiness from happening. Some of the best ways to do that is to replace some of the saturated fats, which typically come from animal foods, but you can also get it from coconut oil, palm oil. A lot of processed foods tend to have higher saturated fat. We want to replace some of those foods with plant sources of fats. So the mono and poly, which I have a question about the poly because there's a lot of controversy around that sometimes. But basically looking at your diet, and this is where the dietitian in me comes in with a Middleish concept and saying, well, if you really love having butter on your toast, maybe consider cooking with olive oil and using the butter in ways that you actually enjoy and, making these swaps a little bit more livable for you. Maybe try a plant-based spread instead of the butter, see if that works. And then furthermore, you can eat more soluble fiber, which you mentioned beans and lentils are great sources, oats, fruits. I mean, there's a lot of different ways. Yeah. Which speaks to the vegan and vegetarian approach that we still haven't sussed out if it's exactly, okay, you're eliminating these kinds of food sources, or are you just adding more of the, plant-based kind of healthy things and giving your body the right tools to actually clear that cholesterol. So I think the overall message is like, you don't have to go super extreme into like a specific, you don't have to turn vegan. Let's just take away some of those principles and say, how can I improve where I'm at right now with a couple little swaps?
Yep. Just a shift, a slight shift makes it. I mean, I posted one today, but just some of those shifts, depending on how extreme you are, but it may look as if you're taking a medicine for cholesterol. I mean, 30, 40, 50% sometimes drop. And it's like, whoa, that's a big deal. So when people are like, food is medicine, I'm like, okay, I mean, it depends on your perspective. It's medicine if you're eating certain things and switch it to a different thing. And there may be genetic things where the food may not make a huge difference, but I don't know. Depends on your perspective. I'd say food is medicine depending on the situation.
Sure.
So I have a quick case study that I just want to share real quick. And then I do want to come back to polyunsaturated fatty acids because it's kind of controversial. But this quick case study I wanted to share was from a client that we'd been working together for 3 months, which is a pretty standard kind of let's make some changes and see how it affects your lipids. Is that pretty fair? Yeah. So total cholesterol went from 260 to 200. Triglycerides from 185 to 124. LDL from 192 to 158. So we saw all of these really great improvements just from, and again, these were pretty simple. Like we just worked week to week about educating on swapping out some foods and trying some different things. But her HDL, which is quote, the good cholesterol, went from 31 to 17. So tell us your thoughts on that.
Yeah. So HDL is a risk marker, but it's not a causal marker. And what that means is that it tends to be that those with higher HDL, to a point, by the way, once you get to that 80 and above, it may be actually inversely related. Once you get super high, it may actually be a risk factor. But what we found is that people who have low HDL levels, if we try to raise it in any sort of way, it doesn't change their outcome. It just happens to be that those people with higher HDL tend to do better. And the reason is it has to do with, it's a marker of metabolic health and insulin sensitivity. So those with lower HDLs overall, so being 30 with that higher triglyceride that she had before, she probably has a little bit of insulin resistance going on regardless. So, and then when it drops down to 17, it's probably a marker of just eating less saturated fat in general. That by itself of lowering, it wouldn't bother me, and it's probably not an issue. So, and then artificially trying to increase it just by having them eat more saturated fat or cholesterol, it won't do anything. It's just simply a marker that's there of cardiometabolic health, but not causal, meaning it's not actually going in and doing anything else to help us. That's what we used to think of it as this recycling truck. It's going in, it's grabbing cholesterol from stopping the macrophages from eating things up. It may have some of that, but like honestly, we just can't measure it yet. And we don't capture it from the cholesterol on the HDL particles. And that's all we're doing. We're seeing the cholesterol and the HDL particles and hoping we find something from there. But come to find out, it doesn't matter if we change that number or not. In the future, we think we're going to be able to potentially check the activity of the HDL particle, because that's what probably matters more, this efflux, how well it's taking out cholesterol out of the different arteries. We're not there yet, and whether we can even modify that, we can't yet. Probably exercise and stuff like that, stuff that we already know. But beyond that, I wouldn't worry about that. I would say that that client probably has some insulin, some leftover insulin resistance, so getting them to lose weight regardless is a good idea. But you've already helped them lower their LDL cholesterol and probably ApoB. You can actually measure ApoB. It's probably the thing of the future as well. And that's the thing, the ApoB count, the number, that's probably even more important than anything else. So I'd say you did benefit in that person, and there's still residual risk left over that you can work on.
Cool.
Interesting. Yeah.
Okay.
So let's talk real quick before we go to Polly. Let me go to Polly.
Polly.
Yeah, Polly.
We're
talking Polly. We're talking
Polly.
Polly.
What about
We'll see what happens.
Let's see where this goes.
Yeah. Let's talk real quick just about exercise and what role does that play in heart health? What sort of place does it hold as far as importance, when we look at nutrition and exercise and that kind of stuff? And then how does it help improve heart health as well?
Yeah. So there's there's two different components. There's the component of this particle getting stuck into your artery and starting the atherosclerosis cascade. But what about the actual artery itself? And what about the immune system and inflammatory system once the particle becomes stuck? There's all sorts of components. So people say that LDL particles are causal, and they are, but there's multiple causal components in there once that particle gets stuck. And there's things that may increase the ability for that particle to get stuck. Basically, the artery can become more susceptible to the particle being stuck. Like if the particle doesn't get stuck as readily, that's a good thing. So think about like smoking. Mm-hmm. Smoking increases our ApoB a little bit, but it also damages our arteries to where these particles can get more readily stuck in there, and our system will probably more readily start attacking and starting atherosclerosis. So hypertension, increased blood pressure may increase the risk of these particles going into our arteries. It may damage our arteries. Insulin resistance, also the same thing. So this is where you see the people getting in fights about, like, is it LDL or is it insulin resistance? It's both. The LDL particles are still the thing that start it, but like we want to be as insulin sensitive as possible so that we have healthy arteries. So this is where exercise comes into play. Exercise improves the health of our arteries, essentially. So, and there's different types of exercise. Obviously, I like resistance training, but aerobic training, a little bit both. I would say a combination of both probably improve our artery health a lot. Endothelial function, the lining of our artery, the endothelium. In which case, I would exercise as much as possible. It also, if you can get some weight loss with it, with the exercise, then it can lower our particle count. But where I think it helps the most is probably endothelial function, which is the artery health, and insulin sensitivity, and just overall metabolic health there.
Mm-hmm.
Yeah.
So I love that. So nutrition, we're looking at sort of like what's happening inside the arteries. Exercise, we're just making the arteries stronger, more resistant to what's happening inside of them.
Yeah. Healthier overall.
Yeah.
Awesome.
So when you put these, and I will come back to Polly, she's coming.
Polly.
When you put these together into, I mean, of course, we both follow you on Instagram, and social media isn't always, a reflection of how you would treat somebody, right? With your clinical practice, your telehealth. So what's your approach with translating some of these, very specific recommendations into a personalized approach for somebody when you see these risk factors and you kind of hear what their lifestyle is like? Give us an idea of what kinds of things you might come up with that client.
Yeah, I do a lot of like dietary patterns. So, okay, so someone comes into your clinic, they haven't had a heart attack yet. So we're talking about primary prevention. We want to prevent the first event from occurring. Then there's something called primordial prevention, which is even before that, where we want to prevent the risk factors from even occurring. It doesn't really matter. We want to stop this person from getting heart disease and having a heart attack. So you can do something called one of these ASCVD, atherosclerotic cardiovascular disease risk calculators. It's a calculation. You put all their stuff in, and they've had so much data that they can see based on these called traditional risk factors, what's their risk of having a heart attack in the next, or some sort of event in the next 10 years, and it spits out a number. So we youngins, it doesn't even work for us because we're so young. But once you hit 40 or so, these calculators start being able to spit out certain things, and that's what you generally do. I don't actually do these calculations specific, because I can look at somebody and look at their numbers quickly and have an idea of this person's moderate or high risk without even doing a specific calculation. So someone that comes in and they seem to be kind of low risk and they're doing a good job. And their LDL cholesterol and everything, it looks all pretty good. I just have them, maybe give them some recommendations, but keep them doing what they're doing. But if somebody comes in a little bit more, higher risk, and then we just have a discussion like, what are you eating? And what are these different things? And what can I do to help this person? So in terms of dietary pattern, we shift more towards like those simple things, like you said, if that's just for lowering their LDL. But then I'm also an obesity specialist, so I try to get people as lean as mean as possible. And I have a degree in exercise science, and so I'm a shill for exercise as well. So my goal for each person is
big exercise.
Shill for big exercise. Trying to get, if they don't exercise, trying to get them to start if possible. If they have an unhealthful dietary pattern, trying to improve that, and then help them get leaner if possible as well. Around that 5 to 10% weight loss, which seems to be the most sustainable long run, unless I'm giving them medicine for weight loss. So that's pretty much it. Trying to shift them to that dietary pattern that improves lipids and insulin sensitivity, not one or the other. And you can come up with different cases, but that's somehow shifting them towards that spectrum. If we can get them to start walking more, they have a low cardiorespiratory fitness. This is where people get so confused. They're like, I feel like I have to punish myself and run miles a week to get better. But the biggest benefit is actually right in the beginning. Once people are active, the benefit of increasing your activity, you'll still get some benefit potentially up to a point. But the biggest benefit is just starting. People are extremely sedentary. There's a huge jump in mortality benefit. At least, we don't have these randomized trials. This is epidemiological data, but we're pretty sure that like if we can get people just a little bit better, they have massive improvement in their risk of dying. And so that's it. I just try to shift them a little bit.
That is so encouraging to hear. Like, I think everybody needs to hear that. Like, just a little bit, just getting started really can move the needle. And do you find that you mentioned, like, we're not trying to work on just, blood lipid profile or just insulin resistance. We're trying to, work on both of these things. And I would say overall health in general, like mental health and like emotional wellness and that kind of stuff. I find in my practice that a lot of these recommendations firmly overlap with each other. So when you're recommending like, hey, let's add a couple servings of lentils to your week, how might that look? How can we figure that out? You're not only helping with heart health, but you're also helping with digestive health. You're probably moving the needle on weight and obesity just by being fuller longer. You're probably, helping in all of these different ways. You're getting a more fibrous, complex carbohydrate instead of that simple carbohydrate. Like there's a lot of different things that are at work there, plus the vitamins and minerals in that food. Same thing with like a exercise recommendation, right? You're helping with mental health and stress relief and all of these other things, not just, we're trying to lose weight or trying to like help your heart be healthy.
Right. People focus in on these small quantifiable markers, and there's a lot of things about health that we just can't quantify. So that's, I mean, that's what I get into when I talk about, can you be healthy when you have obesity? Yeah. I mean, I don't know. Are any of us healthy when we look at the real definition? I don't know.
Yeah.
Start looking
No,
at
that's a
that
great
stuff.
point.
Right.
I wanted to ask you about that since you're an obesity expert and I see that you put body positivity things out there too.
Yeah.
I'm really curious about the intersection with those two in your practice.
Yeah. So, I mean, the gist is like, look, am I health at every size? No, because I feel like there's a lot of people that get so extreme to that side, but there are a lot of people that won't lose as much weight as they want to. When we look at the studies, around 5 to 10% of weight loss seems to be doable for the majority of people over the course of a year or longer. Do the best you can. If you want to do more, you maybe need surgery or medicines, but do the best you can there. Focus on dietary patterns and behaviors. Focus on exercise, which may or may not have an impact on the scale. And if we can do those things, like if you can't lose weight, you're frustrated because everybody wants to lose weight, like, well, try to get stronger, get fitter, focus on your dietary pattern, even if it's not even if you don't get that much weight loss from it, you can still have a cardiometabolic benefit. We talked about the lipids. It can shift without losing weight. You can have a big shift there. So that's kind of my mantra. Despite being an obesity physician, there's some people that will paint me in a way like, you just care about their weight. I'm like, honestly, trying to get people healthier, whether if they want to lose weight, I can help them. But if not, we'll try other ways. That's literally what I do. So,
well, what I love that you said, that's such a great point to not having to be extreme is, I mean, you're talking about like 5 to 10% weight loss can have a really good impact on your overall health. And people think, oh, if I'm 200 pounds, if you have a 200-pound female, she probably thinks she needs to weigh 130 to be a healthy person. But it's like, man, 10, 15 pounds, if your weight's negatively impacting your health, this can seriously make a big difference. And I'm really glad you said that, because that's just, how it is. I mean, it's got to be extreme, and it's got to be, pedal to the floor and do all the things at once. And if we're looking at improving health, well, that's maybe not the way to go about it.
Yeah, you got it. Yeah. I think it's
that's awesome.
Expectations and perceptions, and helping people with that. It does change the way they like. So in my Lift RX group, there are lots of people that, they yo-yo diet in the past. I'm like, just forget about dieting right now. Focus on a dietary pattern. Sure. Like focus on good stuff. But if we can get you moving, you get you feeling good, getting stronger, like that's a big win right now. So let's focus on that.
Yeah. I think that's an excellent message. And I also love that you mentioned health at every size. We've talked briefly about that on the podcast, specifically with Mark Breeden. I don't know if you know Training Strong Women on Instagram. He does really great stuff that's very similar to your approach to let's just get more people working out. And he specifically focuses on let's get more women strength training and working on this. But I love that health at every size is becoming a more normalized approach in medicine. At least I hope it is, that there are practitioners like you that are saying, look, let's focus on behaviors and the things we know help with overall health, the not smoking, the healthy dietary patterns, the moving your body a little more, those kinds of things. And let's not just focus on you have to drop this much weight, because I think people feel really defeated when they've tried and tried and tried, and they've done all these diets and all these extreme things to get weight off, and it just keeps coming back on, but not focusing on the consistency of the core practices that we know make a healthy human body.
Yeah, I think, like I said, I post about this, people get so angry, but I'm like, the average weight loss.
Everybody's angry on the internet.
Everybody's
Spencer.
Angry. Comprehensive weight loss program can get to around that 5, maybe 10% at the most, but it's not really usually. It's usually like 6 or 7%, but over the course of a year, and then it starts dropping off to maintenance. So it's like, okay, well, I lost 100 pounds. I'm like, yeah, it's possible. There are a few people that will respond really well and be able to keep it off. There are also a lot of people that don't lose any weight. And then there's a bunch of people in the Middleish, this is the podcast, the Middleish.
Hey, nice plug.
Middleish. They will lose around there and hopefully maintain as much as that possible. So then it's like, okay, what are we doing here? Well, yeah, I can offer medicines. You know, some people may agree with that or not. I personally think they're great. If you go and like, look, this person, I think the weight loss, the actual scale weight is important for this person to improve their health. We have that option. But there are a lot of people that are like, you know, I'm comfortable in my own body. I feel fine. Like, and I'm metabolically good. My knees don't really bother me too much and that type of things, where it's like, okay, let's just keep you like as active as possible, keep you on a healthy dietary pattern, and let you live your life. Like, why not? I don't know. But you know, that argument isn't very popular in the fitness professional world. And it's like, well, let's let people live.
Right.
Like, why do you have to bother people? I mean, I'm a
Yeah.
doctor,
Right.
so I will, you know, I can bring it up and discuss it with a patient without having to be a jerk about it. Some doctors don't bring it up at all. That's not necessarily the right way. The right way, I think, is the right way is asking permission to talk about it. And if somebody doesn't want to talk about it, it's like, all right, whatever, okay.
We'll
Go
focus
about
on
it.
other things. We have lots of other things to work on, talk
Yeah.
about.
And some people don't want to be weighed at all or have nothing. So I'm like, okay, well, we don't have to talk about that. Although I'm in this obesity specialist position. They're coming to me for weight loss. So
Yeah.
in the general clinic, that was my how I would work. I'm like, all right, you don't want to be weighed, and it may ding me on insurance, but I'm not going to force you to get on the scale if it traumatizes you. Like, what's the point of that?
Well, and let's just acknowledge that stress is a huge contributor to, you know, heart health and just overall health as well. And so my camp is sort of, if it creates undue stress on you to be so worried about the number on the scale and your anxiety goes up because you have a birthday party coming and you don't know how to handle it, then we're going to focus on the things that help you feel calmer and just more settled in it, at ease in any food situation. So you have the confidence to navigate that yourself. So
yeah.
Should we reintroduce Polly since we've circled back around?
Polly.
Let's talk about Polly.
Well, you did just talk about internet anger. And so I think this is a prime, you know, fodder for that. A lot of people have this perception that polyunsaturated fatty acids are actually inflammatory, specifically omega-6. Canola oil is bad because it's super refined, even though it's strong in the monounsaturated fatty acids. So how do you handle those? I mean, you're the expert. Here we go.
Yeah.
How do you handle those discussions?
Like, okay, it's like, oh, the hypothesis is, and this goes back to the biochemistry. So I guess I have to talk about it.
Buckle up.
So the saturated fats, they don't have any of the double bonds in the structure, whereas polyunsaturated has multiple double bonds, monounsaturated has one. So in terms of oxidizing these, and it's a biochemical reaction, oxidation. The more double bonds you have, the more prone to oxidation. Now, atherosclerosis occurs when a lipoprotein and the stuff contained on the lipoprotein, including fatty acids in the cholesterol, everything, something becomes oxidized, but it doesn't have to be oxidized. It could actually be modified. But so if you have more polyunsaturated fat on one of these LDL particles per chance, and it becomes stuck in your arteries, it's possible it's more readily oxidized. So the hypothesis comes up, wait a second, these polyunsaturated fatty acids are bad. Well, in practice, it doesn't actually, that's not actually what happens. Your LDL particles go down, and there seems to be no real clear signal that an increased risk of atherosclerosis happens from polyunsaturated fats. In fact, the inflammatory markers and things we look at, those don't seem to change. So CRP, that's only one. And it's not specific, but there's other multiple inflammatory markers they look at. And it tends to be those who eat the most polyunsaturated fats seem to have the least amount of heart disease. So now here's the deal. Like, I'm not telling people to drink corn oil. Again, that's a high, like that's straight up omega-6.
Thank God.
But I suppose it's possible if you replace your butter with corn oil. I would suspect that you probably would have a decreased risk in heart disease. Although, like, again, like the reason corn oil would ever be associated with it is because you're eating tortilla chips that are in corn oil. So like, but honestly, if you're focusing on
Mhm.
nuts and seeds and fish and things that are whole sources of these, I hate to play the natural fallacy or whatever it is, where if it's from nature, it's healthy. But like these foods packaged together from nature tend to have certain compounds in it that protect oxidation and all sorts of stuff. So like walnuts are high in polyunsaturated fat, but walnuts decrease endothelial inflammation, improves endothelial function, lower lipid LDL particles, and are overall healthful, not inflammatory at all. So anyway, that I would say if you're getting it from whole sources, it just doesn't matter. So
Yeah. I think that's a good recommendation for people to hear, is like focus on
Mhm.
some of the whole natural sources as much as you can, and take a look at maybe the nutrient packages that are associated with, we don't eat nutrients in isolation, which is one of the things that's been screamed from the rooftops for years, but it's really hard to suss out from these recommendations, how do we translate that to whole foods? So I think you've done a great job.
Yeah, I'm glad you mentioned that about walnuts, because it is easy to, we talk about like, what fats are healthy and that kind of stuff. And like you're saying too, Aaron, it's really easy to isolate them, but that's not how we eat them. And that's not how they impact the body. There's a whole lot going on with what else we've eaten. And even, with like you said, with walnuts, like there's other things that are happening here that are worth considering. So I'm really glad you mentioned that. So if someone, let's say just, you got general pop, Joe Schmo kind of person who's just wanting to not only improve their heart health, but also just keep tabs on it. What do you recommend as far as sort of do you just recommend an annual physical for people after a certain age to have, labs drawn? What do you recommend for people keeping tabs on where they're at as far as heart health and, risk for heart attack, stroke?
Yeah, there's certain ages and risks. I mean, honestly, everybody should at least get one every few years of a lipid panel. If you can get an ApoB, that would be great. I'd suggest everybody gets one of these new genetic tests. It's the lipoprotein little a, at least one time in their life. It's a special lipoprotein that some people make too much of has extra atherosclerotic potential. But yeah, lipid panel every so often. If something changes, if you change your diet to keto or some new type of diet, you want to do it within a few months and see how the diet's treating you. Or at least the next year when the doctor says, we don't need to get labs, you say, well, I have changed this, or I've gained a lot of weight or lost a lot of weight. You want to repeat it. If you're stable, something won't change much in a year.
Okay. That's good to know.
Right.
Yeah.
Do we have anything else?
I'm good. Anything else you wanted to throw out there?
No. I think I just texted my wife to get my charger because I think my computer's going to die.
Oh.
Well, we'll wrap it up. Let's wrap it up. So this is when we do meaning in the mundane. Yeah. Would you like us to go first?
You guys go first and then let me think.
Okay.
That's my move. Aaron, you go ahead. Yeah.
Okay.
Let you go.
Do you want me to start then? All right. So mine was, I just got back from Mexico, which of course was not mundane because it was really my first true vacation with my husband in 8 years. So it was not mundane, but I had one morning where I went for a run along this path in the little village we were staying. And it was just, I had mapped it out, I swear, but it ended up being much longer than I had anticipated. And I just ran down to this gorgeous beach where it kind of opened up, to the ocean. And when I turned around to run back, I checked my little watch and I was like, oh, this is kind of a long run. And at some point on the return trip, I just had this heart full of gratitude that my body can do this kind of thing where I can just head out and explore this new place on my own 2 feet. And maybe it was poorly planned, or maybe I didn't plan to run as long as I did, but just being very, very grateful that like, hey, I can go out and just run and my body can handle this. And I get to smell and see and feel nature at the same time. So that was my moment.
Awesome. That sounds pretty all right.
It was A-okay.
A-okay.
Great way to start my day.
Heck yeah. For me, mine was Sunday. Yeah. So I took Sophie, my 5-year-old, to there's several little parks in our neighborhood, and we went to one that we hadn't been to before, and had this really cool playground with all kinds of cool stuff to climb, and like a climbing wall, and that kind of stuff. And so she wound up in certain positions or places on this playground where she was either forced to like, hey, daddy, you got to get me down, or I'm going to dig deep here and do some things that scare me. And so we got to just a couple different times. I got to, as a parent, thankfully I was just kind of aware of this, but just sort of go through these moments of like, hey, you know what you get to do right here? You get to choose to do something that's scary and do it with safety, because I'm here. Like, you're not going to fall. I got you. But to practice being brave, right? And practice doing things that feel hard for you. And so we got to do a couple of these in the hour or so we were there. And it was cool. On the way home, we were having this conversation about being brave, and she was saying, well, daddy, I was pretending to be brave. And I was like, yeah, that's awesome. You were pretending, like she was essentially pretending to be someone who was brave. And I was like, but the cool thing about that is you're the one that had to do that. Like, you're the one that had to be brave, even if you were pretending that was you. And so you're the one that did that. So you were the one that was brave. And it was just a really cool moment of, we go to parks a lot and play, and usually there's other kids there, that we've gone with that she's playing with or something. But it was just this really cool moments where, you kind of got to invest in your kid and open their eyes to what's really happening here, and how the things that they're doing are really positive steps for them, and expanding, their ability to believe in themselves and that kind of thing. And yeah, it wasn't expected. I was just going to, let's just go play, but it was a nice little time of some good development there. Yeah.
I like that.
Yeah.
Cute.
Yeah. So you got one, no pressure.
Well, so no, recently I'm an entrepreneur at heart. And I will say that I'm always thankful to think about, like, recently how, like, I have a big safety net. If worst comes to worst, I'll just go work in a clinic as a non-meme doctor on podcasts a few times a week. So it's always saying, especially, you're talking about your kid. It was like my kids hug me, and I'm always like, man, I'm thankful I'd be able to provide for them, even if it meant I wasn't able to do these memes. So big safety net, I can go and try do things like this and get my brand and stuff like that out there. So pretty mundane, but it's a good place to be.
No, that's good. And it's
awesome.
always great to practice gratitude, especially if you do have that entrepreneurial spirit. I think Michael and I can relate to how much pressure that can build sometimes. Like, if you're not, producing and creating the things that you visualize, but bringing it back to, man, I'm really grateful for kind of where I am and what I have at my disposal. That's good.
Yeah. Good place to be.
Love it.
Good.
Well, thank you for being here. We really appreciate your time, and it's always really good to chat with you and pick your brain.
Yeah, thanks for having me.
Have you drop knowledge on us.
Future conversations.
Yeah, we'll do it again.
We're going to have an Instagram live, everybody, with Dr. Nadolsky. This will be on Monday, the 21st of March.
21st, yeah.
At 8:30 Mountain Time.
9:30 Central, 10:30 Eastern. Yeah.
Mm-hmm.
Yeah.
Yep.
And hopefully I'll be there. I might not be there.
Yeah.
But it might just be Aaron and Spencer.
Michael might be on spring break in Cancun. Is that what we decided?
Cancun.
Sure. Camping, Cancun, same thing, right?
Okay, so hopefully you all can join us for the Instagram Live. Thank you again so much, Spencer.
Thank you so much.
And we'll talk to you soon.
Thanks.
Good one.